First, let's begin with recent information which was presented at the 2016 American Society of Hematology meeting regarding the use of interferon alpha. Over time, it has been of interest to look at this therapy in patients with myeloproliferative neoplasms. Interferon has been used in the past in diseases including chronic myeloid leukemia, as well as in single-arm studies in patients with polycythemia vera, as well as essential thrombocythemia. The use of hydroxyurea has been utilized based on demonstration of a decrease in thrombotic risk, with the strongest data being that for patients with essential thrombocythemia, and there remains concern about the long-term safety of utilizing hydroxyurea in patients with polycythemia vera. The long-acting forms of interferon, pegylated interferon alpha, has been associated with activity in terms of molecular response as well as control of elevated blood counts in single-arm studies. It is on this basis there were two randomized phase 3 studies which have been recently reported. The first, a trial in which I was involved with the Myeloproliferative Disorders Research Consortium, led by myself, my colleagues Dr. John Mascarenhas and Ron Hoffman from Mount Sinai, who lead that consortium. This was a study of high-risk patients with essential thrombocythemia and polycythemia vera. An upfront study in terms of frontline therapy with Hydrea versus pegylated interferon alpha 2A. These individuals would then be receiving the therapy with endpoints regarding control of the disease, the counts, and rates of vascular events. Overall, what we identified is that through 1 year of time, it could be most accurately said that interferon was non-inferior to hydroxyurea, and that the rates of control were similar in both groups of individuals, with overall response rates being 81% for those individuals with pegylated interferon alpha 2A and 69% for hydroxyurea. Next, we had looked at the molecular response rates and identified the molecular response could be identified in individuals both with the use of hydroxyurea and that of interferon. And this is to complement what had been seen in the literature up to this point. There have been reports of the ability to control molecular allele burden in patients with PV with interferon. The data with hydroxyurea is relatively new. It does demonstrate that both are active. Now, there still remains the question whether interferon will be superior over a longer period of time, and that 12 months may be an inadequate amount of time for us to assess that difference. The second study used a different formulation of interferon, and this may well be relevant over time. This is the Ropeginterferon alpha 2B. This is a drug notable by its ability to be given every 2 weeks, as well as having primarily one isomer in its formulation. This trial was specific for patients with P. vera, randomized between the Ropeginterferon versus hydroxyurea. This trial similarly had a 12-month window of report, but then a continuation study looking at better molecular response over a longer period of time. What they identified is that this trial was a non-inferiority analysis, and that it could clearly be said that the interferon was non-inferior to hydroxyurea through 1 year of time in terms of control of blood counts, splenomegaly, etc. Symptoms were not evaluated on this particular study. The authors similarly discussed at the American Society of Hematology meeting that in the ongoing study, the CONTI-PV study, that there may well be superiority in terms of molecular control with the interferon arm, but that there will be more time necessary to be able to make those conclusions. In terms of these two phase 3 studies, I would say that both treatments show robust control of the disease from a hematologic perspective. Both trials show that there is non-inferiority of interferon compared to hydroxyurea. The two drugs have different safety profiles, and it's not clear that there is superiority of one drug over the other in terms of toxicity. In the PROUD-PV study, they did find that there were secondary malignancies that did appear in the hydroxyurea cohort compared to the interferon cohort. So overall, would conclude these segments by highlighting a few key observations. The diagnosis of polycythemia vera is determined by using both major and minor criteria outlined in the WHO's 2016 revised classification of myeloid neoplasms and acute leukemia. The management begins with near universal use of aspirin and the control of the hematocrit in all P. vera patients. Selective use of cytoreduction continues to be utilized based on risk. In my practice, I consider cytoreduction in all patients that are not low risk. Basically, no significant cardiovascular risk factors, no significant symptoms, no other risk factors. Frontline cytoreductive therapy is currently based on risk in hydroxyurea and is primarily hydroxyurea, interferon in women who are pregnant, potentially in younger patients, also in clinical trials. Ruxolitinib has been FDA approved for patients with polycythemia vera who've had an inadequate response to hydroxyurea. Ruxolitinib has durable benefits for these patients with improvement in erythrocytosis, leukocytosis, thrombocytosis, so elevation in those counts, improvements in splenomegaly, improvements in disease-associated symptoms, and likely also in reduction of vascular events. There are emerging treatments that may further clarify the role of interferons that may have promise for safely improving symptoms and potentially other longer-term outcomes in patients with these difficult diseases.